Thomas's Brighton, and his research interests include bifurcation, coronary artery disease, left main disease, and angina management. And he's been involved in a number of trials involving Revive2, Syntax2, LM Ideal, the left main ideal trial. And we'll hear your viewpoint on syntax, fame, and ischemic myocardium.
Well, I'd like to thank the organisers. It's a real honour to present here. And it's difficult to follow that talk, actually, and that is a tough act to follow. What I'd like to say is I'm going to talk about syntax, fame, and the ischemic myocardium. I've got no conflicts of interest to declare, except that I am a rather simple interventional cardiologist. And it's my personal views that I'm going to discuss. So what we're discussing today is we're going to look at the syntax score. We're going to be revisiting things that you guys know very well. We're going to look at fractional flow reserve, the fame study, and what a functional syntax score might bring around, and then conclusions and what the outcomes of a functional syntax score may be. So first of all, I think let's just clear the decks and say that there are some givens in multivessel disease, some things which I think are incontrovertible and are not for debate. The role of the MDT is not in question. That is something now which is essential and pretty much should be mandatory. And by the MDT, that also means the patient meeting the cardiologist and the surgeon to have informed consent. Patients are a heterogeneous group. If everybody was a 65-year-old male, life would be much easier, but they're not. And particularly nowadays, we're getting patients at the extremes of age and comorbidity, and these are the patients that never feature in trials. So it is difficult, and patients should be looked at as a heterogeneous group. Revascularization, whether it is by PCI or by CABG, is on top of optimal medical therapy. And that means that patients must be aware that whether they have a bypass or stents, they're going to be on an aspirin, statin, blood pressure control for the rest of their natural lives. Certain patients, undoubtedly with multivessel disease, are best served with coronary artery bypass grafting. Oops. Probably there are patients with multivessel disease who are best treated with PCI, and undoubtedly some patients will do well with either. We have the syntax score here, and this is teaching you things you know, but this is obviously a quantitative assessment giving you regards to the number, location, and complexity of lesions. And it gives you scores 0 to 22, 22 to 32, and greater than 33. And as we know with the 5-year outcomes of syntax, where in the low tertile of 0 to 22, there didn't seem to be much difference really between PCI and bypass. However, in the intermediate and high-risk groups, there was a significant difference, and in the high-risk group, that included mortality. So the syntax score gives us an accurate, objective assessment of coronary artery disease. When split into tertiles, it's predictive of MACE, particularly for PCI, not so much for CABG, where the outcomes were pretty much the same across the board. In syntax trial, patients in intermediate and higher tertiles had better outcomes with CABG out to 5 years. And in a recent pooled analysis, the syntax score is predictive of mortality, stent thrombosis, and MACE rates. And this is reflected in the current guidelines. We can see here that for multivessel disease, once you get down to the intermediate and high levels of syntax score, PCI not recommended. But there are limitations to the syntax score. It is purely angiographic, and it is not, so it doesn't look at function, and we don't know whether the lesions are significant. There are no clinical variables. There is inter-observer variability. There's no assessment of viability. You're unable to discriminate between individual components. It would be nice to be able to say you've got a syntax score of 32, so you're at a higher risk of repeat revascularization or death or something, but you can't obviously discriminate that. And it doesn't take into account operator ability. There are a lot of different abilities of different operators, be they PCI or CABG. So coming from that, is it important to know that the myocardium that you want to revascularize is actually ischemic? So this is a trial looking at myocardial perfusion scanning in the United States, where you see that as you increase along this axis, you see that the myocardium is becoming more ischemic, and then you have cardiac death up the side. And you can see that when there is no ischemic myocardium, revascularization actually does harm, and you do well with medical treatment. But as you move along, you can see that actually revascularization, and this was equally CABG and PCI, was life-saving as you got to the more ischemic myocardium. But we need to know, is this lesion causing myocardial ischemia, and what's the best way of doing this? Well, the best way, in my opinion, is with an FFR. And I'm sure you know this, but an FFR is where you pass a wire down a vessel, past the stenosis, and then you'll be able to get a ratio of the distal pressure to the proximal pressure, and over time and through various trials it's been worked out that significance is at 0.75 to 0.8. So if a lesion is greater than 0.75, it is not causing ischemia. If it's less than 0.75, it is responsible for ischemia. It is significant. But we also know that there is a poor correlation between FFR and actually us assessing angiograms. When we look at coronary lesions on angiograms, it's quite possible to either overestimate them or underestimate them. And as was mentioned earlier on, it goes both ways. However, particularly for intermediate lesions, so 50 to 70%, a significant amount, 65% will be suggested to be significant when actually it turns out they're not. That obviously becomes less as it becomes tighter, but you can see that it does cut both ways. Sometimes things are thought of as to be not significant when actually they are. And from the DEFER study, we know that this is, I think, 500 patients who have their FFR assessed, and when the FFR is greater than 0.75, it is safe to defer, i.e. not treat them, and actually you end up doing them harm with PCI if you treat them when the FFR is not significant. And this led to the famed study, which was fractional flow reserve versus angiography, PCI in patients in multivessel coronary disease. 2 or 3 stenoses, so multivessel disease, either having their PCI guided by angiography alone, so the operator deciding whether the lesions were significant or not, or compared to by being guided by FFR. Initially 1-year follow-up. And from their results, there was a significant benefit to patients of being FFR guided in terms of death, heart attack, CABG or repeat PCI. And this actually was significant out to 2 years. And then when we take the results from FAME of PCI-guided FFR and bring in a similar definition of MACE from the patients in syntax, we can see that the FFR-guided PCI, you're approaching levels that were achieved by surgery in the syntax trial. So can we combine syntax scores with FFR to predict outcomes? And this has been done to create something called the functional syntax score. It's a combination of then an anatomical syntax score with knowing whether lesions are significant or not. And in the FAME study, there were 1,000 patients and approximately 500 had FFR-guided PCI. They calculated their syntax score, but also their functional syntax score. And that's the functional syntax score is the syntax score, but only counting lesions which were producing an FFR that was greater or was less than 0.8, so i.e. significant. And you can compare that with the syntax score with the functional syntax score. And so what are the first effects of it? Well, first of all, you can see this is the syntax score. And then what happens is you're moving patients from the higher groups down to the lower tertile when it goes across the functional syntax score. So you're moving groups from the higher and intermediate risk into the lower risk where both PCI and CABG are viable options. And then also you can see that what happens is when you look at functional syntax score of the higher risk groups, they really are significantly more in danger from PCI because they're getting bad outcomes here. But also it's showing good discernment. You're getting a statistical difference between the groups. So the functional syntax score decreases the number of higher risk patients and pushes them more to the lower and intermediate risk categories. It is a better discrimination of MACE risk. I haven't shown the data, but it's an independent predictor of 1-year risk of MACE. There is less inter- and intra-observer variability. However, there are no clinical characteristics, only 1-year outcomes, unlike Syntax, which goes out to 5 years. It's not really a direct comparison because FAME had 2 and 3 vessel disease, whereas Syntax was 3 vessel disease. An FFR is time-consuming and it is invasive. So at the moment, it's probably more hypothesis generating than certain. So what is my own personal view then of this? Well, first of all, I personally believe that angiographic assessment of intermediate lesions is no longer acceptable because patients who have PCI or are grafted of a non-significant stenosis, and there is data of grafting of this, it is not a good thing to be done. Some patients will need to be treated with CABG, some will do well with PCI, and some will do well with both, if multivessel disease. Myocardial ischemia is the driver for revascularization, so there's a need to know that your lesions are functionally significant. And if functional Syntax score is pushing more patients into the group where they can have both PCI or CABG, then patients must be informed regarding the short and long-term benefits of both options. But this functional Syntax score needs validation, direct comparison, and long-term follow-up. And this is happening in some trials, but as was alluded to earlier on, FAME3, which will be an or is currently enrolling an FFR guided PCI with current generation drug-eluting stents versus coronary angiography, bypass based on coronary angiography alone. Any questions?